Okay, thank you, Lydia. I think Lydia and the guy, you need to see each other and talk because there were some questions I think which were not adequately answered. It could also have been good for other listeners to get the response, but because we are on borrowed time. So I would like you to clap hands for our presenters for a wonderful presentation. Then lastly, a very short story. I would also want you to clap hands for me because these 3 sessions had no moderator because I'm seeing my supervisors, they are here. So they would ask me, why did you moderate? Maybe you got something from Icasa. So these 3 presentations, they had no moderator. I had just to come in to save the plane from crashing. Thank you. So clap hands for me. Thank you. I think there are now other presentations. I'll ask the moderators to come. Thank you. Whilst the other presenters are presenting, Gerald, Dennis, and Lydia and Walter, I can come for a photo shoot whilst other presenters are preparing. Sorry. Thank you.
Ladies and gentlemen, welcome to the next session. I'm going to invite our speakers, if you're in the room, to help us save time. Please come up. I will introduce you as soon as we start. So our 3 speakers, if you're in the room, please come up so we can get ready to start. Hi. Hello. Excellent. There's Oluwashola. There's another one. There's another Nigerian. In the middle. No. She's the first speaker. Thank you. Good afternoon, ladies and gentlemen. Everybody, welcome. Welcome to the session. Today's session is from track C on epidemiology and prevention science. This session is going to focus on HIV prevention technologies. Today's presentations, in case you didn't catch it in the program, features 3 abstracts that were selected as the best abstracts in the epidemiology and prevention science track. So before we begin, please join me in giving a huge congratulatory round of applause to our presenters. The presentations today will explore critical and evolving approaches to HIV prevention and care, with a focus on gender-responsive research, vaccine acceptability, and long-acting prevention options across African settings. We will hear evidence on the links between female genital schistosomiasis and HIV risk. We will examine global and contextual factors influencing HIV vaccine acceptability. And we will explore CAB-LA, long-acting cabotegravir, as an innovative prevention option to improve adherence. All of that drawing from real-world program experience in Botswana with other evidence from Nigeria. Together, these presentations highlight the importance of strategies focused on people and built on evidence to inform improvements in equity and fairness in access to HIV prevention and health outcomes. We look forward to the presentations and to thoughtful discussions and insights. So we will start with about 10 minutes from each presenter. So please stick to time to allow us to give about 10 minutes for questions and exchange with the experts in the audience, at which point we will then return to the speakers to respond, if they may, to some of the questions raised. So without further delay, ladies and gentlemen, I'm pleased to introduce our first speaker, Ms. Oluwashola Balogun, a passionate public health professional and a Master of Public Health candidate at the University of Ibadan, specializing in health promotion and education. Her journey in public health is driven by a strong commitment to strengthening health systems and improving service delivery, particularly for young people and underserved communities. She has worked extensively with NGOs and public health programs across Nigeria. Today, Oluwashola will be presenting her abstract entitled Overlooked and Misdiagnosed, Female Genital Schistosomiasis and its Implications for HIV Risk in Endemic Nigerian Communities. Please join me in welcoming her.
Good afternoon, everyone. Good afternoon. Okay, so I am Oluwashola Balogun, and I'm pleased to be here to present today to you a research that was carried out in Nigeria, and I hope that you like it. All right, thank you. Okay. So I'll be speaking on female genital schistosomiasis in relation to STIs and HIV, and I will be talking briefly on what female genital schistosomiasis is. It is a neglected manifestation of schistosomiasis hematobium, and the symptoms include vaginal discharge. It also includes postcoital bleeding, abdominal pain, and all of that. So why are we so bothered about female genital schistosomiasis? It is a hidden reproductive health crisis that is emerging. It is often excluded reproductive health programs, and it is misdiagnosed, which is the major reason this research was carried out, because it's often misdiagnosed for other STIs rather than it being female genital schistosomiasis. And when we neglect or misdiagnose FGS, it has so many issues that it causes, and that is the significance of the study. So the study assessed clinical awareness and diagnostics practices. It identified systemic barriers to FGS recognition and management. It recommends strategies to integrate FGS into policy and practice. The methods used was a qualitative study using in-depth interviews, that's IDI, and the participants in total were 12 health workers, nurses, midwives, and community health officers. The setting analysis, we used the thematic analysis. So key findings, let me not bore you with the details. 15% of the healthcare workers received formal training on female genital schistosomiasis, which is a very, very low percentage. 15 out of 100 is very low. So many of the healthcare facility workers said they've never received training on female genital schistosomiasis. Also, 70% misdiagnosed symptoms of STIs or cervical issues. 85% said FGS is not in training curricula. Okay, so discussions. Why are we focusing on this? FGS affects millions of women and girls in sub-Saharan Africa, yet it is rarely recognized in health systems. Many cases go undiagnosed because symptoms mimic other reproductive health conditions, just as I said earlier. The lack of awareness results in prolonged suffering, infertility, and increased vulnerability to HIV and cervical cancers. So the gap in training is a major issue that was highlighted. Then the stigma that comes with gender norms and all of that. Part of the risks is that it's mainly gendered because of the roles women play. Going to the streams to wash, going to the streams to bathe, and all of that. Most of the things that women do with water exposes them to the risks of female genital schistosomiasis. So the call to action, there is an urgent need for policy, action, training, and community sensitization. There is need for awareness, advocacies. When we talk about advocacy, we're talking about evidence-based advocacy. Social and traditional media also can be used to pass across information regarding FGS. Women's voices matter when we talk about FGS, and then multi-sectoral partners can be used can come on board rather, to talk about FGS and put an end to it, or at the best, still minimize to a great level. So recommendations, I've talked about that a little bit. So we need to integrate FGS into health curricula and diagnostics guidelines, improve diagnostics tools, and have it at the PHC levels, because that's where it is most needed, since FGS mainly affects women in the rural areas. We also can launch a gender-sensitive community education at the community level. Thank you.
Thank you so much. I think we can do better at congratulating our speaker. That was an excellent presentation. I'm very pleased to introduce our second speaker, Mr. Uzochukwu Chima. He is a graduate pharmacist from the University of Nigeria, Nsukka, and an emerging global health researcher with a strong interest in pharmacoeconomics, public health, and patient outcomes. His journey in research is driven by a commitment to generating evidence that informs health policy and supports equitable healthcare delivery. Today, Uzochukwu will be presenting his abstract entitled "A Scoping Review of the Impact of Vaccine Characteristics on the Acceptability of HIV Vaccines, Current Global Trajectory of Evidence." Please join me in welcoming Mr. Uzochukwu Chima.
Good afternoon, everyone. I'm before you to present my abstract on a scoping review of the impact of vaccine characteristics on the acceptability of HIV vaccines, the current global trajectory of evidence. Okay, this is a summary of what we'll be looking at. The major questions we need to ask in terms of the development of HIV vaccine, which is a very important prevention technology in the fight against HIV, is how do the different characteristics of vaccines influence the acceptability of these HIV vaccines pending when they will be rolled out? From our study, which we are going to see, we're able to see that efficacy has a very great impact on acceptability, including side effects, cost, and duration of protection. Why does it matter? It matters most because the high uptake of these vaccines is dependent on the user preferences, which we synthesize from the evidence from our research. So developing a safe and effective preventive HIV vaccine remains the most promising long-term strategy for controlling the global HIV/AIDS pandemic. Although these vaccines, they have a strong potential in fighting HIV, we can see that the real-world uptake of this vaccine, the acceptability of this vaccine is greatly dependent on how acceptable it is across different populations. However, this acceptability may be strongly shaped by their characteristics, their individual characteristics, such as efficacy, side effects, cost, and dosing schedule. Now, the evidence examining how these vaccine attributes influence user preferences is quite limited and scattered across populations, settings, leaving an important research gap. Understanding how these characteristics matter most in how we are going to design this vaccine, in how we are going to communicate how this vaccine would be helpful for the general population, for the key population, and also the implementation planning once this vaccine become available. The aim of this study is to determine the impact of vaccine characteristics on the acceptability of future HIV vaccines. Now, in our methodology, we use the Hanksy and Ocheli guideline of scoping review, and we're able to see that from our initial search, about 1,228 studies we collected from different databases, and through our inclusion criteria, which includes for the population, we looked at studies that examine both general population and also at-risk population, that's the key populations. And the intervention we are looking at is the future HIV vaccine characteristics with outcomes ranging from the impact scores of these characteristics and the acceptability ratings of the individual vaccines that were examined. In the study design, we only recruited or included studies that were peer-reviewed and have conjoint analysis as one of the study design that were adopted in those various researches. And after further screening, we were able to only include 11 studies based on this inclusion criteria. Please, next slide. Okay. Now, the key terminology we need to know about this study is that we included studies that adopted the conjoint analysis. This conjoint analysis, it helps us to understand how people make choices when multiple factors are involved. Now, we are not just looking at the general picture of will people accept HIV vaccine. No, we want to know if we bring in many factors such as efficacy at different levels, cost at different levels, side effects, whether mild or severe, and also the dosing schedule, whether it can shape how or it can distort their acceptability of these HIV vaccines. So in summary, the conjoint analysis identifies the relative importance of each vaccine characteristics, how it compares with other characteristics in determining how people will accept those vaccines. And in conjoint analysis, the importance that people give for a particular characteristic is expressed either as impact scores or utility values. Now, the question we are about to answer based on our findings is, how do user preferences for vaccine characteristics influence the acceptability of future HIV vaccine rollouts? In our results, as I said earlier, we included 11 studies based on the inclusion criteria. And as we can see from this table, we will see that majority of the studies were done in developed countries such as USA, Canada, and Thailand. No study was found among underdeveloped countries in African countries, which actually presents us that there is a gap in terms of how we conduct research on how people will accept vaccines. Also, we can see that in the 11 studies that we included, that efficacy and cost were the most predominant HIV vaccine characteristics that were assessed across all the studies. Efficacy, in 11 of the studies, they were predominantly assessed. Duration of protection, only 7 studies. Side effects and safety, only 7 studies. Protection, number of doses, and route of administration, they were only assessed in 5 studies out of the 11. Then, in the impact ranking of these HIV vaccine characteristics, we can see that efficacy ranked first because it was showing it was the most impactful characteristics of HIV vaccine acceptability in 11 studies. The second one was cost, meaning that cost was the second ranking vaccine characteristics across all the studies, followed by side effects, duration of protection, number of doses, and route of administration. Now, the impact score ranges for the efficacy. The score ranged from 15.9 to about 52.4. The type of vaccine ranges from 22.9 to 24.3, and so on. Now, also in the studies, we also saw a particular pattern in how the various vaccine combinations were accepted. And we saw that for efficacy, the different combinations that were done, only vaccines that had efficacy levels of 80 to 90% were accepted. Duration of protection, only vaccines with longer years of protection, 10 years particularly, were mostly accepted by the participants. Side effects, only vaccines that have no or mild side effects were accepted by the participants. Only vaccines with single dose were accepted. And this brings a question of, we know that all these options here are what we can expect in an ideal situation. But in reality, this HIV vaccine that will be rolled out, particularly, most of them might not really have these characteristics. And it brings a question of how we're able to communicate that even though that these vaccines don't have these attributes, that they also will help to fight against HIV. In our recommendations, we recommend that we should promote partially efficacious HIV vaccines, that a vaccine has an efficacy level less than 90, 80% doesn't mean that it won't be able to solve the problem. So we need to promote partially efficacious HIV vaccine through community-driven campaigns, and then we should also see how we can subsidize this vaccine cost, because we saw from the study that only vaccines that were free of charge or that were around $50 cost, that were the most vaccines that were accepted by the participants. We should also prioritize vaccine access in high incidence regions and among key populations. As we can see from the study population of the studies that were included in this review, we're able to see that the studies were centered around mostly the key populations. So in rolling out any HIV vaccine, we should actually make sure that these vaccines are targeted at these particular key populations. In conclusion, from this review, we're able to see that efficacy is the most impactful characteristics influencing HIV vaccine acceptability. And we're able to see that it was only HIV vaccines with high efficacy levels that were quite impactful. Cost and side effects are also one attribute that we can also look at when designing such studies. I would like to thank my investigators in this study and also the person-centered HIV research team who were able to help me in conducting this research. Thank you.
Thank you very, very much for another excellent presentation. So the first presentation showed us why it's important to understand that service providers know what they should be looking for, that they know how to look, how to examine, how to look for those signs so that they can respond. That's the supply side. And now our previous presenter has talked about the demand side. Do our patients know that there's an intervention that will work? And do we understand whether they can afford it and the factors that might affect their acceptance of the interventions? From evidence from West Africa, we're going to turn south, and I'm pleased to introduce our final speaker, Mrs. Tshwetso Yanzi. Please stand. She is the Senior Monitoring and Evaluation Officer at Tebelopele Wellness Centre. She's a results-driven professional with over 12 years of experience in the non-governmental sector, with a strong focus on HIV and detection and care. Mrs. Yanzi holds a bachelor's degree in social sciences, specializing in economics and statistics from the University of Botswana. Today, we're privileged to hear from her as she presents her abstract entitled CAB LA, an appealing alternative to HIV prevention and boosted adherence. The case of Gaborone Tebelopele Wellness Centre, Botswana, which highlights innovative approaches to HIV prevention and improved adherence within program settings. Please join me in welcoming our final speaker.
Good afternoon. Good afternoon, ladies and gentlemen. Like I've already been introduced, I'm Tshwetso Yanzi from Botswana, and I'll be presenting the results from our first month of introduction of the new technology PrEP, which is the long-acting cabotegravir. Unfortunately, I don't know how to use it. Okay, no, I found it. All right, so our background is that globally we are seeing a surge in new HIV infections, as we are having estimation of 1.2 million infections in 2025. And we are seeing that in sub-Saharan Africa, which is where I come from, we are having the AGYWs, or the adolescent girls and young women, that are having 3 times higher incidence of HIV compared to their male counterparts. Now, when we zoom in into Botswana, according to the 2023 Statistics Botswana report, our incidence level and our prevalence rate, they stand at 0.2% and 20.8% respectively among the adults in Botswana. And currently, as I believe we all know, that Botswana have already reached and surpassed our 95 targets, but the struggle is not yet over. We want to see the 100%. When now we zoom in into the topic of interest of today, which is PrEP, we started offering PrEP in Botswana in 2018, and our center, which is Gaborone TWC, I'll be talking about it and denoting it as GTWC, just to shorten it. We started offering oral PrEP in 2018, and our center has been the hub of piloting or just starting the new innovations that are brought forward by the government. And with regards to CAB-LA, which is the topic of today, we started implementing it in 2025, this year in April. So just to give background on where we started with CAB-LA, we started with the trainings in 2024 for the master trainers, those who will be training. And the first group of implementation from TWC, which is our nonprofit making clinic where we come from, we started the trainings in January 2025, and we saw the first lines now in April 2025. So we were looking at the ability for clients to switch between options now that there is a new option on the ground. And we are now looking at how that increase in the PrEP options is going to affect our adherence as well as the access to PrEP for all the populations that are at risk. So zooming into Botswana, for this study, we looked at all the clients that were accessing services at our Gaborone Tebelopele Wellness Centre in the period 23rd April to 23rd May 2025. So what I'll be presenting to you today will be the preliminary results of the period that I've already stated. We had enrolled 129 participants, and the inclusion criteria included all adults HIV negative individuals, except the pregnant women, because currently we are not enrolling anyone who is pregnant on Kebele, Cabotegravir, I'll call it that. And we assessed the risk, and we ensure that there are no symptoms of acute HIV infection, and all our clients, their creatinine clearance is more than 60. So with regards to the methods that we used descriptive statistics that we cross-tabulated, KBLA against gender, age, and population groups, because the data shows us that there's a particular age group as well as certain populations that the incidence rate is higher compared to others. We also fitted a regression model, taking KBLA as a binary action, as a binary dependent variable, and the other population and gender as well as population as predictors. And we use the odds ratio to analyze our results. This is just what I just alluded to in summary. So now the results, we saw that more male, they opted for KBLA, meaning that they were employed with two options to choose between the oral and then the injectable. But we have seen that more uptake was among the male counterparts as compared to the females. And then when we come down to the particular population group, we have disaggregated our populations into the adolescent girls and young women, which in our country, the incidence level is very high of HIV. And then the key populations, the same trends applies to them. And then the general population. So we have seen that in terms of option, our adolescent girls and young women, followed by the key populations, they opted for PrEP as the option that they would take for compared to the oral one. And then when it comes to age, we are seeing that the age groups of 35 to 40, they really opted for PrEP compared to other age groups. Now, this is just a summary in percentages of the table, the descriptive table that I just showed in the previous slide. And then when we go deeper into our results, now we were looking at the statistical significance of our results. And we are seeing that with regards to the key population group, the odds ratio were lower in terms of switching to PrEP compared to the general population. And then that individuals that are aged 25 to 29, they are more likely to switch to KBLA compared to those that are 65 plus. And that there's a confidence interval is at 95% that the true odds ratios as the method that we use lies between the KP and the age group of 25 to 29. Now, our conclusion is that when we expand access to varied HIV prevention methods or options, it is one of the building blocks for a successful global response, which contributes to the decline of new HIV infections. As such, scaling up KBLA and other options that are available nationally, in the case of Botswana, and we believe also globally, is recommended to reach among at-risk populations, as our study was zooming in at the at-risk populations. So I will also end my presentation with the call for action that in the age that we are, we know that different populations, there are different products that appeal to them, and we call for the access and of different products. Like in our country, we have just started with KBLA, and we believe that We will be having another option, which is the Ranakapabe that has just also reached our continent. Thank you.
Thank you so much. Let's give another round of applause to all our speakers. Excellent presentations. Thank you. We now have just under 15 minutes for discussion with our speakers. So I'd like to invite everyone, please. I already see one hand. Please indicate, because we'll have time for maybe 3 questions and then give the speakers the floor to try and answer. So please, one mic over there. Any other speakers? Any other questions in the middle? In the middle, on the side? No, okay. Please go ahead.
Yeah, thanks a lot, presenters, for that presentation. My name is Dr. Pokoro Evezi. I work with the Institute of Human Biology Nigeria. So let me start with the last presenter. I wanted to understand your eligibility criteria. You defined high-risk population, but it wasn't clear how you defined the population as high risk, whether they're FSW, but I know you call them adolescent and young plus KPs. But in a nutshell, I wanted to know, were you measuring uptake of the service or just describing the population? I wasn't getting it to say that 80% uptake. I wanted to get that clear. What proportion of people were you assessing as uptake of Kabele? It didn't come out clear to me to say there was good uptake or there was poor uptake. I just wanted that clarification among that population. Then for Uzochukwu, I wanted to understand what you meant by acceptability. I know you talked about the scoping review, and you had a list of maybe 3 or 5 different points you were assessing: cost, efficacy, and a few other things. I wanted to understand how you defined acceptability. Was it having those 5, pointers that showed acceptability? It didn't come out clear to me what you meant by acceptability from your scoping review. And for the first presenter, you talked about healthcare providers, and you didn't mention physicians. I felt maybe you were biased towards physicians, or maybe your focus was primary healthcare, but you just mentioned community health practitioners, CHUs, and all that. I wanted to know why you didn't include physicians in providers. You wanted to be conscious of female genital schistosomiasis. I just wanted your view on that point. Thank you.
Thank you. Thank you very much. So 3 questions, one for each of the speakers. We'll ask our speaker from Botswana to respond first, and then we'll go to Uzochukwu, and finally the third.
All right, thank you. Thank you so much for the question. So your question was on the populations group. So what we did was everybody who was accessing services into our facilities, we were screening them using the 4 criteria that I flashed there, with HIV negative, at risk, and all that. So in terms of the risk, the population that of interest, we're looking at the numbers of what our statistics are showing at Botswana. And we are seeing that the incidence level is high, or the prevalence level is high among the adolescent girls and young women, as well as the key populations. The key populations include both the female sex workers, the men having sex with men, as well as those who inject drugs. So we are looking at whether when another PrEP option is made available, will that impact the results in terms of the acquiring new infection in those population groups? So I hope that I've answered you.
Thank you.
Not quite.
Thank you. We'll give an opportunity to the next speaker.
Okay, thank you for the question. On your question about the acceptability, in this context, we are asking if the vaccine is available, will they accept to use it? Now, in those individual studies, they were asking them not just whether they will accept to use the vaccine, they were also looking at if these different combinations of vaccines were provided to you, will you be able to still use the vaccine? Not just in the general perspective of, we are giving you this vaccine, will you be able to use it? Now, they are now checking for each of the vaccines that were modeled in the individual studies. They were now asking them, if you have a vaccine A with 30%, 50%, 90%, with a cost of $0, $100, and so on, will you be able to still use the vaccine? So that's what the study was all about.
Okay, thank you very much. And our final speaker?
All right, thank you for your question. The research was carried out amidst healthcare workers, that's nurses, some doctors, also some pharmacists. Yes, so I don't know if I answered your question. Thank you.
Yes, thank you very much. So we did not discriminate against doctors. There were some doctors included in the study. Thank you, speakers, for responding. We still have some more time, so please, if there are not just questions, but we've heard very important information about supply side, addressing capacity gaps, and ensuring that providers are ready to provide the appropriate services. We've heard again about the demand side, making sure that we understand our patients' preferences, but also what makes our interventions acceptable. There are lots of people in the room with lots of experience in these areas. I invite you, if there's an addition that you'd like to share, please to go ahead. There's a hand over there. Thank you.
Thank you very much. My name is Batsi Makunike. I'm from Zimbabwe. My question is to Oluwashola on female genital schisto. I'm a health worker many years, but also for me, female genital schisto is something quite new, So for us, schisto as it is looked at as a neglected tropical disease. But I'm trying to understand, how do we diagnose female genital schisto? Is it a diagnosis of exclusion? Because like you're saying, there's a lot of misconception and misdiagnosis, because maybe that is one of the big issues. Is there a rapid test that we can use to be able to diagnose it so that we can integrate it with HIV? I'm just trying to understand.
Okay.
Thank you very much. Let's see if there are any other questions or suggestions, comments from the floor. We have a very shy audience this afternoon. Okay, please, go ahead.
Okay. Thank you very much, ma'am, for your question. So female genital schistosomiasis goes through a series of lab tests. So there is a swab that is done, and then that is taken to the lab, and it goes through a lab test, actually. So it's not a rapid test. There's no rapid test for FGS yet. And the reason it is misdiagnosed is because the symptoms are close to that of other STIs. And yes, so that's the basic issue behind the misdiagnosis, because the test process also follows some STIs. It's not all STIs that has rapid tests. As things like gonorrhea and all of that, those have rapid tests, but FGS doesn't. So it goes through lab tests, and sometimes the symptoms or the results sometimes the symptoms, yes, are close to those of other STIs, and that's why it's usually misdiagnosed. And there's a drug for prevention and also for treatment, praziquantel.
Thank you very much for clarifying. I'd like to take advantage of the silence a little bit to ask about young women. In your data from Botswana, you showed a chart showing that older women tended to prefer Kabele more so than the younger women. Did I read that correctly? What did you actually find about young women? Because PrEP, when it was initially, all the research has initially been driven a lot to make sure that we give options that are more acceptable and accessible, especially to younger people who are so often excluded from interventions that they can control. Did your research actually reinforce that? Or did you find something interestingly opposite?
Yeah, yes, I was trying to look for this chart, but as you can see from numbers, in terms of the aggregate numbers, 76%, which is the adolescent girls and young women, is the one that constitutes a higher percentage, which is something that is interesting, because now when we go down into the statistical analysis, we are seeing that now the age group, which is older than the age WRWs, they are more statistically significant. But in terms of the choice and opting for Kebele, the young girls were opting for Kebele. Yes.
Thank you. Thank you very much.